Hi, my dear students and colleagues. I hope all of you are doing well. Welcome to my channel. I'm Dr. Salah Shaheen, Professor of General Surgery, Qasr Al Aini Hospital, Cairo University, Egypt. In this video series, I'm going to present some important clinical syndromes, especially those related to surgery. The difference between syndrome and disease. The word syndrome comes from the Greek words. Syn means together and rome means run. That's to say, running together. A syndrome is defined as a recognizable complex of symptoms and physical findings that indicate a specific condition for which a direct cause is not necessarily understood, while a disease is defined as a condition manifested by distinguishing signs and symptoms and usually has a defined or understood cause, process, and treatment. Now, let us start by Frey's syndrome, which is also termed auriculotemporal syndrome. The first few minutes of this video is dedicated for those who are interested in history. If you are not, you can skip this part simply by pressing the forward button. Dubois had described gustatory sweating over the cheek area in relation to experimental sectioning of cervical sympathetic nerves in horses in year 1860. Dr. Jules Bialargé, a French neurologist, first reported the phenomenon in 1853, describing two patients who were treated by incision and drainage for parotid abscesses. Patients later developed facial sweating during meals. He explained the facial fluid as saliva overflowing due to plugged Stenson's duct. Weber in 1897 was the first to report a case of bilateral gustatory sweating and flushing in a patient who undergone bilateral parotid abscess incision and drainage. The first accurate description of this phenomenon was provided by Dr. Lucia Frey, a Polish Jewish physician and neurologist, in 1923. She described a 25-year-old female who sustained a gunshot wound to the parotid region and subsequently developed facial flushing and sweating 5 months later. She accurately identified the autonomic innervation of the parotid gland and the auriculotemporal nerve as the link between gustatory stimulation and facial sweat production. In 1927, Dr. André Thomas, a French neonatal neurologist, theorized that the pathophysiology of the disease involved apparent nerve regeneration. 5 years later, Dr. Peter Passou reported the first case of Frey syndrome after parotoidectomy. Nerves related to Frey syndrome. The parasympathetic supply of the parotid gland is secretomotor. The preganglionic fibers originate from the inferior salivary nucleus in the medulla and travel with the glossopharyngeal nerve. Then fibers pass through the tympanic branch of the glossopharyngeal nerve, or named Jacobson nerve, that join the tympanic plexus. From there, the preganglionic fibers pass through the lesser petrosal nerve to relay in the otic ganglion, which is present in the infratemporal fossa. The postganglionic fibers reach the parotid gland through the auriculotemporal nerve. The sympathetic supply of the parotid gland is vasomotor and also innervates the sweat gland of the face. The preganglionic fibers arise from thoracic segment T1 and travel through the sympathetic chain to synapse in the superior cervical ganglion. Then the postganglionic fibers form a plexus around the blood vessels. The sympathetic supply of the parotid comes from the sympathetic plexus around the middle meningeal artery and then passes through the otic ganglion without relay and reach the parotid gland through the auriculotemporal nerve. Auriculotemporal nerve also carries general sensation to the auricle and temple, like touch, heat, cold, etc. The great auricular nerve with root value C2 and 3 supplies the skin over the parotid gland, the lobule of the ear, and over the mastoid process. Pathophysiology. The auriculotemporal nerve may be damaged in trauma to the parotid region or during surgical procedures like parotoidectomy. Both sympathetic and parasympathetic axons are cut. With the nerve regeneration, the parasympathetic axons undergo apparent regeneration and grow along the sympathetic axons to cross-innervate the vessels and the sweat gland of the face. This causes vessel dilatation and sweat production in response to gustatory stimulation. What is a Frey syndrome? It is a gustatory flushing, sweating, burning, neuralgia, and itching in the region of the ear and cheek in response to food mastication or a salivary stimulus like smelling or seeing food. Causes. The commonest in adults is post-parotoidectomy, with incidence of 5 to 60%. It occurs about 6 to 18 months after surgery. Less common causes include neck block dissection, facelift procedures, deep trauma to the parotid region, infection in the parotid region, temporomandibular joint surgery, mandibular condyle fracture, instrumental vaginal delivery. Clinically, the symptoms appear weeks, months, or even years after the initial insult, as the apparent nerve regeneration takes time. Generally, the symptoms are mild, but can result in discomfort as well as social anxiety and avoidance of eating in public. Examination may show signs of prior surgical intervention or trauma in the parotid region. The diagnosis is based mainly on clinical history with a starch iodine test as confirmatory testing. How to do the test? Paint the affected area with iodine and let it dry. Then dry starch is applied to the painted area and a salivary stimulus is given. The starch turns blue or brown in the presence of iodine and sweat. Management. This includes prevention, which is done at the time of surgery. The idea is to create a physical barrier between the postganglionic parasympathetic nerve endings within the transected parotid gland and the sweat glands in the overlying cutaneous tissues. For established cases, medical treatment is the main line of treatment. This is accomplished by topical application of antiperspirants and anticholinergics. The most effective treatment is by Botox injections. Surgical treatment is rarely indicated and is reserved for refractory cases where medical therapies are no longer effective. Let's start by prevention techniques. Many techniques have been described. These include increased skin flap thickness, or by the use of a physical barrier either by local tissues like fascia or muscle flaps, or by the use of free fat grafts, or the use of acellular dermal matrix ADM grafts. These techniques all have associated risks and disadvantages like prolonged operating time, varying effectiveness in preventing Frey syndrome, wound infection, and postoperative complications. Examples of these techniques are increased skin flap thickness. The sweat glands are positioned at the same level or slightly deeper than the base of the hair follicles within the facial skin. It has been presumed that increasing the thickness of the elevated skin flaps by including fat and superficial musculoaponeurotic tissue can theoretically protect the sweat glands and prevent the apparent parasympathetic nerve regeneration. Other technique is the use of transposition muscle or fascia flaps. Pedicle muscle and fascial flaps have been used to cover the resected parotid gland in an attempt to create a physical barrier between the overlying dermis and the transected nerve fibers within the parotid. Like the temporoparietal fascia flap (TPFF) based on the superficial temporal artery. But creation of this flap requires an extended incision. Also, this flap doesn't provide sufficient bulk to reconstitute the parotid bed. This procedure requires a second reconstructive team that increases the overall cost. In addition, the temporal branch of the facial nerve is at potential risk for injury. Local transposition muscle flaps include platysma and sternocleidomastoid flaps. The platysma muscle flap is designed by elevation of the skin of the parotoidectomy incision superficial to the platysma muscle. But this carries a risk of skin flap necrosis. Also, the marginal mandibular nerve is at risk for injury. Sternocleidomastoid flap is harvested from the upper one-third of the muscle based on the occipital artery, with the advantage of greater bulk to reconstruct the parotid bed with minimal donor side complications, but there is a risk of accessory nerve injury. A good technique is the use of a cellular dermal matrix (ADM) graft. It is an extracellular connective tissue graft generated via decellularization process wherein the cellular components of the dermis are removed. Multiple ADMs may be used to reconstruct defects after total parotoidectomy. The last technique is the use of autologous fat implantation. Free abdominal fat graft is used to ameliorate the post-surgical contour defects and improve cosmosis. The potential for donor site morbidity like hematoma, infection, and seroma may make this technique a less attractive option. As regards medical treatment, the topical antiperspirants like 20% aluminum chloride solution, may help control of sweating, but their effects are mild and occurs in less than 50% of patients, with duration of improvement less than a day. The anticholinergics also can be used. Systemic atropine is not effective in preventing sweating, and if anhidrosis occurs with its use, it is usually a sign of atropine overdose, like tachycardia, blurred vision, respiratory distress, etc. The patient can use local anticholinergics like scopolamine hydrobromide gel 1 to 3% or glycopyrrolate cream. They have been found to be effective to reduce the activity of the sweat glands without significant side effects, but frequent application is needed. Alcohol injection of the otic ganglion has historically been employed, but can result in anesthesia to the mandibular division of the trigeminal nerve, which can cause even more bothersome symptoms than Frey syndrome. Botox botulinum toxins injection is the best medical treatment. It acts as an anticholinergic and blocks acetylcholine release at the neuromuscular junction. That's to say, produces chemical denervation of the sweat glands. The average dose is 0.1 milliliter of a 75 units per milliliter solution intradermally for every 4 centimeters square of involved skin. The peak effects are apparent within 4 to 7 days of injection. However, its effect diminishes over time. Thus, repeat injections are often necessary as symptoms recur in 27% and 92% of patients at 1 and 3 years respectively. Repeat injections are safe, decrease the area of the affected skin, and increase the symptom-free duration. Surgical treatment. The options are transection of the auriculotemporal nerve, but it is technically challenging in a previously operated field, or tympanic neurectomy. The glossopharyngeal nerve may be transected, but the risk of an intracranial procedure is not justified for a benign condition. Also, transection of the greater auricular nerve may be helpful. Another option is placement of a physical barrier, as discussed already in the prevention techniques. The last option is excision of the affected skin with grafting for the defect, but this creates an unacceptable cosmetic results for the patient. If you are interested to know some information about Lucia Frey, you may pause this part of the video and read it. After finishing the Frey syndrome, some comments should be remembered about the Frey's procedure. It is a surgical procedure for the treatment of chronic pancreatitis. This operation was first described by Frey and Smith in 1987 and was published in Journal of Pancreas as a new operation for chronic pancreatitis. Surgery for chronic pancreatitis in general is indicated when the intractable abdominal pain is not amenable to medical and endoscopic therapy. The Frey procedure is indicated when the head of pancreas is bulky. This means more than 4 cm with no suspicion of malignancy, and the main pancreatic duct is dilated. This means more than 5 mm in diameter. Basically, the procedures is a resection of the head of pancreas with duodenum preservation, combined with Drainage of the main pancreatic duct. The first step is to open the duct throughout its length to within 1 centimeter of the tail and into the pancreatic head, followed by coring of the head of pancreas and the uncinate process, leaving a rim of pancreatic tissue left on the duodenum and portal vein. Then a lateral pancreatico-jejunostomy by row-on-crack anastomosis is done using a single-layer continuous suture 4-0 polypropylene. The jejunum is sutured to the capsule of the pancreas or to the mucosa of the open duct. Finally, jejunostomy is done 60 cm distal to the pancreatic anastomosis. This picture shows the opening of the main pancreatic duct, and this one shows coring of the head of the pancreas. This picture shows the pancreas after finishing the excision. The yellow arrow denotes the duodenum, the blue arrow for the main duct open, and the green arrow for the cored head, while the yellow circles are the sides of the stay suture, which are hemostatic and help the coating of the pancreatic tissue. This picture shows the final results after finishing the jejunopancreatic anastomosis. When compared to pancreatico-jejunostomy or Whipple operation, the Frey's procedure has less operating time, less blood loss, less ICU stay, less hospital stay, and in general it has a lower mortality and an acceptable morbidity. This part of the video is only for those who are interested in history. Charles Frederick Frey, the Emeritus American Professor of Surgery, is presented in this part of the video. Thank you for watching this video. It is first part of the series Surgical Syndromes. I hope it was clear, well illustrated, and very informative. If you feel like that, please give a thumbs up and share it with your friends. Your subscription to my channel is of utmost importance to me and will help me making more videos covering most of the surgical topics. Don't forget to hit the bell so you will be notified whenever I post a new video. Finally, if you have any query or a question, don't hesitate. Write it down and send it to my channel, and sure, I will respond in time. Best of luck. See you soon. Goodbye.